So whenever we are looking at menstrual bleeding, we know that it is of abnormal quantity, duration, or schedule is known to affect about 10 to 35% of women. And it interferes with their daily activities, causes anxiety, especially fear of uterine cancer is profound. So if there is absolutely no bleeding for a period of 12 months, then it is amenorrhea, which requires evaluation. If it is regular, where the variations are plus 2 to 20, then that is plus minus 2 to 20 is taken as regular. Remember, anemia is a prothrombotic condition, so be a little careful when you're giving this medicine to her. And always look for TE risks and avoid. And periconceptual safety is been mentioned, but it's definitely something which is questionable. So what is saline sonography? You pass a saline in the uterine cavity and do a sonography, and you can see that it got delineated, and this diagnosis became endometrial polyp.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Hello, good evening, all the Medflix audience, and it's indeed a pleasure. Thank you, Sanika, for that kind introduction. It's definitely a pleasure to be here on this forum once again after many days. And today we are going to discuss one very, very common problem that we as gynecologists face, and generally all of us as doctors face in our practices, where women suffer from what is called as heavy menstrual bleeding. So, in today's session, we are going to have a little practical approach, and this practical approach is going to be in the sense that we are going to discuss some cases and what is new and what's happening. So, let's hold on and feel free to ask for any questions or anything in the chat box, and I hopefully should be able to answer them. So, whenever we are looking at menstrual bleeding, we know that it is of abnormal quantity, duration, or schedule is known to affect about 10 to 35% of women, and it interferes with their daily activities, causes anxiety, especially fear of uterine cancer is profound, and that actually drives many of the perimenopausal women coming to the clinic. And plus, they're quite frightened, they're worried whether they're going to get menopause or not, and what's happening to them, or there is any pathology inside. About 5% of women aged 30 to 49 seek evaluation for menorrhagia. And iron deficiency anemia is very, very common. And many times I see doctors treating the abnormal uterine bleeding, but forgetting to give corrections for anemia, which is very important because otherwise she'll get into a vicious cycle and keep on having bleeding and anemia sequencing. So, as Sanika mentioned, there's something called as PALM-COEIN classification. This has made our life very easy because then we are able to categorize the patient, properly ask the history, and try to find out whether this particular problem that she's having is related to that particular condition. So the palm, typically the palm that is polyp, adenomyosis, leiomyoma, malignancy are structural abnormalities like a palm. And there are non-structural, or which we can call as functional abnormalities such as coagulopathy. Sometimes women, as the later part of their lives, may develop idiopathic thrombocytopenic purpura. Around menarche, they may have puberty menorrhagia. There can be women who are on anticoagulation therapies for their other illnesses, which can be the reason. And ovulatory dysfunction can be there, where there's lack of progesterone and uncontrolled and dominant action of estrogen. There can be an endometrial reason where the endometrial is not responding to the hormones inside the woman's body. Iatrogenic causes. Sometimes we give medicines for some reason, or they don't take them properly, or sometimes they may have taken over the counter medicines for some abnormal uterine bleeding or pill postponement. So that can be the reason. And then there are certain other things like non-classified. For example, in this picture, we've written ischemocele. Sometimes after a C-section or any surgery on the uterus, there can be an AV malformation, or there can be an ischemocele at the scar site, and this can cause intermenstrual bleeding, and that also is a cause. So we have to then individualize and try to evaluate the patient correctly. So by and large, these are the challenges that we face as far as AUB is concerned. Now, when a patient comes to you with panic and anxiety, it's very important that we identify that this is abnormal. And therefore, it's very important to have this kind of a reference maybe on your consulting table so that you know whether this is normal or abnormal. So, frequency of menses, usually if it is less than 24 days, so 24 would be normal, 24 less than 24 would be frequent, 24 to 38 would be normal, and more than 38 can be infrequent. Regularity of menses, that is cycle to cycle variation over 12 months and days. So you can give them a menstrual log, and they can put their cycles and give you an bird's eye view as to what's happening to the menstruation, so that then you can correctly point out what is the problem. So if there is absolutely no bleeding for a period of 12 months, then it is amenorrhea, which requires evaluation. If it is regular, where the variations are plus 2 to 20, then that is plus minus 2 to 20 is taken as regular. While if it is variation more than 20, then it's taken as irregular. Duration of flow 4.5 to 8 is taken as normal, while more than 8, less than 4.5 is abnormal. Heavy is more than 80 ml of blood loss, and normal is 20 to 80 now. Less than 20 is taken as light. Now, friends, many times when women complain to you of clots coming out, or if they say that there's a lot of flooding, then that means it's a heavy menstrual bleeding, and that requires an understanding. Because if the patient has adenomyosis, the uterus will not contract appropriately, and therefore there'll be flooding. If she is bleeding and having clots, that means the fibrinolysin, which is present in her endometrium, is not lysing, because normally the menstrual blood is undergoes lysis because of the lysine in the endometrium. There's so much bleeding that that lysine is deficient, and that is the reason why there'll be abnormal uterine bleeding. So whenever a woman says this, we have to remember that she requires help. Now, how do you choose a treatment? First and foremost, it is based on various factors such as etiology, then severity of bleeding, especially if it's leading to anemia or is interfering in her daily quality of life is compromised, or if she has associated symptoms and issues such as pelvic pain, or is she wanting to get pregnant. And we all know that when the endometrium is bleeding abnormally, or if there is any other reason why she's having abnormal bleedings, that may be contributing to her lack of getting pregnancy. So that has to be looked into. And then if she has any contraceptive needs and plans for future pregnancy, medical comorbidities if they are there, rule out and wherever look at risks of venous thromboembolism and arterial thrombotic events, and patient references regarding as well as access to medical versus surgical and short-term versus long-term therapies. So all these will decide how you're going to approach your patient of abnormal uterine bleeding. Now let's look at Arunima. Arunima has been menstruating 8 days through 10 maxi pads per day daily with clots, so that is heavy. She has fatigue but is not dizzy, desires to conceive her second child next year, does not smoke, and she, in her past medical history, has type 2 diabetes. Vitals are afebrile, blood pressure 138 by 71, heart rate is 80, BMI is 40.2. So this gets classified as obesity class 3. And on pelvic examination, we find that there is moderate amount of blood in a vaginal vault. And then what do we do next? Of course, because she's in a reproductive age group, we will first and foremost do what? We will do her urine pregnancy test. Especially women in reproductive age, whenever they have abnormal uterine bleeding, always rule out pregnancy. And you can see that Arunima's pregnancy test has come negative. So now we have to decide what next. So the next thing is that we have to now see why is she bleeding after her pregnancy test has come negative. She's 35 years, has had one child, no abortions, and has been having this kind of heavy bleeding for the last 5 months. So what is the next best approach that you can do for her? Always that you have to first give her hemostatic medicines. So you can see her, we can give her a combination of mefenamic acid and tranexamic acid, because mefenamic acid improves platelet aggregation and degranulation, and therefore it causes hemostatic plugs which are transformed and causes decreased bleeding. Ensure to give it in the right dose. Remember, our Arunima is a little plump, is a little obese, so she will require a good dose of 500 milligram TID or BID, and she has a tendency of acidity, then it's always better to give it with a H2 receptor blockers and with food. And then tranexamic acid. Now tranexamic acid is known to cause stop heavy menstrual bleeding because it brings about fibrinolysis and then conversion of plasminogen to plasmin, and it's known to be extremely effective, can be given in the dose of 1 to 2 grams in a day. There are certain red flags which we are going to discuss, but the first line of treatment is try to stop the bleeding. maybe even for a temporary time, but don't allow that woman to bleed and get further exsanguinated. That gives her a whole lot of confidence, and then you can help her with the rest of the things. Now, coming to tranexamic acid, it has advantages which may, while especially if the woman is trying to conceive, like our Arunima, then it can be taken only during menses rather than daily. And disadvantages are there is a theoretical risk of thrombosis, which is controversial, and I have not experienced any such kind of an episode in my patients. Probably I'm choosing them correctly. And what are these choices? Look at risk of thromboembolism, be careful. Concurrent use with combined oral contraceptive pills for short term only should be advised, not for a long term basis. Remember, anemia is a prothrombotic condition, so be a little careful when you're giving this medicine to her. And always look for TE risks and avoid. And periconceptual safety is been mentioned, but it's definitely something which is questionable. Now, which non NSAIDs do you give? Ibuprofen 600 milligram OD is good enough. Mefenamic acid 500 to 250 milligram BID, TID, or QID. Or you can consider giving the cheaper one, that's naproxen 250 or 500 milligram BID, TID, or QID. And start from the first day of a periods. Caution, periconceptionally, it's better to avoid NSAIDs. So give it only during the time of the menstruation. Don't give it prolonged. And combination of with tranexamic acid is safe. Now, the advantages would include that it doesn't increase risk of thrombosis. There's low risk of adverse effects, reduction in dysmenorrhea, very important, low cost and often available over the counter. Unlike most hormonal therapies, they do not need to be taken daily, and we have to just give it temporarily for that period of time. Now, is there any evidence to support this kind of an approach? A systemic review of RTs of women with HMB concluded that NSAIDs were more effective than placebo at reducing HMB, but less effective than LNG-IUS, which is especially the 5251, that means which contains 52 levonorgestrel intrauterine system, and which is eligible for AUB treatment for 5 years. Now it's been extended for contraceptive uses till 7 years, and tranexamic acid. This review also noted that the efficacy of naproxen and mefenamic acid in treating HMB were similar. And in comparison with OCs, a small RCT of only 26 patients was conducted in women with HMB found that a low dose monophasic combined OC appeared more effective than mefenamic acid or naproxen in reducing the menstrual blood loss. So, but these are not statistical, so use your wiseness and be there uniquely making your treatments tailor-made for your patient. So now evaluation of abnormal uterine bleeding in a non-pregnant reproductive age women, how do you go about it? So this is a wonderful algorithm where initially, as we did, is the uterus source of bleeding, first find out if there's uterine bleeding or is there any extra uterine bleeding, whether there is anything in the ovary, fallopian tube, cervix, vagina, vulva, urinary or gastrointestinal tract. Evaluate the etiologies of other sites of bleeding. Is the patient premenopausal or postmenopausal? If she is premenopausal, then you will treat now as we are going and seeing Arunima. If it is postmenopausal, then evaluate the etiologies of postmenopausal bleeding because she may be having a malignancy, should be a priority when we are looking at it, and ask her for any iatrogenic causes. And is the patient pregnant? So in our case, we found that our patient is not pregnant. And if she's pregnant, then evaluate for etiologies of bleeding during pregnancy. So this is a very rough algorithm which should come to your mind quickly whenever a patient with abnormal uterine bleeding comes. So now what do you do next for our Arunima? Watch next. So we did a 3D ultrasound, and you can see a beautiful picture of this 3D ultrasound where she's showing a submucous fibroid. Now we all know that submucous fibroids are known to cause heavy menstrual bleeding, and therefore they are not only causing heavy menstrual bleeding, but they will also come in the way of conception. And secondly, they may not respond to the medical management of therapy. And then her hemoglobin was 9 gram per deciliter, which is anemic. And pelvic ultrasound shows a large submucosal fibroid, as you can see here. And therefore, she gets classified as abnormal uterine bleeding L, AUBL, as we saw in the PALM-COEIN classification, oblique. So AUB because of leiomyoma, which is submucous plus anemia. So this will be her diagnosis. So what are the surgical options we have? The gold standard for submucosal fibroids in women desiring pregnancy is the direct removal of fibroid, which will improve her fertility outcomes. Be very careful not to damage her decidua or the endometrial lining. And safe and effective, especially if the fibroid is accessible irreversible and less than 5 centimeters. Can medical management work? Yes, but with limitations. And here we can consider tranexamic acid and NSAIDs temporarily till her anemia improves. Because if you decide to do a surgery when she's anemic, there are chances of infection and sepsis which can happen. So it's always better now. All the guidelines mention that the hemoglobin before any surgical intervention, especially a planned surgery, should always be 10 grams or more. So you have to improvise. Until that time, you can give her tranexamic acid and NSAIDs, but remember, they're not going to shrink the fibroids. So are there others? Yes. We have GnRH agonists which can be used like mifepristone. Now, mifepristone has shown efficacy, and we have now derived a lot of experience from our COVID experience where we couldn't directly see patients. So we are doing online consultations. And many times when mifepristone is given in a dose of 25 milligram OD and then tapered over a period of 3 months, giving them 10 milligrams BID and then 10 milligrams OD over a year, we are able to control these fibroids. So till the time her anemia comes back, you can consider giving her mifepristone. And this may be used preoperatively or temporarily manage symptoms, but does not address the structural cause, that is fibroid. Maybe the fibroid will reduce in size as well as bleeding will reduce in size. So where does she classify? As I told you, when we are looking at the AUB picture, submucosal AUB. L is her diagnosis. So that is where she is. And when do you do a hysteroscopic myomectomy? Is performed when other therapies have failed, or it is reasonable to attribute symptoms to any intracavitary fibroid. And indications are dysmenorrhea, leukorrhea, necrotic leiomyoma, and certain histological findings. Postmenopausal bleeding can also be the reasons why you would do. And usually in a postmenopausal, we will suggest the patient to directly undergo a hysterectomy and not go into all these kind of issues. Now, can we place an LNG IUS? So now we have to remember that this is Amina, who is 42 years. She had 4 children and she had heavy menstrual bleeding. And her primary doctor diagnosed her as AUBA, that is adenomyosis and leiomyoma. But the doctor failed to do her fibroid mapping on ultrasound correctly. And she was anemic, and therefore he said that let's put in an LNG IUS, that is levonorgestrel intrauterine system, which was inserted 5 months back. And she continued to bleed. And you can see what has happened. This animation went. You can see that we did her a hysterectomy, and it actually was a big submucosal fibroid. And naturally, she was not going to respond. She's already 42. And we decided. So, this was not a good idea of using an LNG IUS because the contraindications for levonorgestrel intrauterine segment system is an intracavitary or cavity obliterating fibroids and submucous fibroids. So remember this, and this should not be then given to the patient. Now let's come to 49-year-old woman with 3-day history of HMB, irregular cycles and intermenstrual bleeding over past few years. There is no dysmenorrhea, bilateral tubal ligation 10 years ago. Physical examination shows stable vitals, no hypovolemia or bruising. And it's always better to ask these histories. And perimenopausal age, always remember to rule out malignancy. Now, what are the various tests that you must consider? Complete blood count, which because it will tell you about anemia, microcytosis, thrombocytopenia. If the platelets are low, then there is some coagulopathy which requires to be found out. Or if the platelets are very high, that means she's been bleeding for a long time and therefore platelets may be high. Ferritin, because it's a good marker of iron deficiency. If it's less, then that tells us it's an IDA. Prothrombin time, when factor 7 if prolonged in isolation. APTT, where factor 8, 9, 11, and 12 if prolonged in isolation. Thrombin time if prolonged with hypofibrinogenemia, dysfibrogenemia, or heparin, which if she's taking already for some reason. Fibrinogen, where there is hypofibrinogenemia or dysfibrogenemia. Von Willebrand's profile should contain von Willebrand factor antigen activity and factor 7 laden. And platelet aggregation testing, assessment for aggregation and secretion abnormalities. So always also consider coagulation issues where are they acquired or have they started now. So, so when we look at AUBC, remember that we have to look at certain red flags. So initial screening for an underlying disorder of hemostasis in patients with excessive menstrual bleeding should be structured by medical history, where look for positive screen, compromise any of the following: heavy menstrual bleeding since menarche, if she has a history of postpartum hemorrhage, surgery-related bleeding, bleeding associated with dental work, or two or more of the following symptoms, such as bruising 1 or 2 times per month, epistaxis 1 to 2 times per month, frequent gum bleeding, and family history of bleeding symptoms, and minimum laboratory evaluations such as CBC, peripheral smear, ferritin and coagulation panel, and secondary evaluation can be the von Willebrand panel, plasma VWF antigen, riscositin cofactor activity, and factor VIII activity. Now, von Willebrand disease is identified to be present in 13% of women with HMB, so we have to be sensitive and aware of these conditions, which can be responsible to give her bleeding. Now, so in let's look at Aruna, who had pregnancy test negative, pap smear was performed, and she was within normal limits. Which of the following is the most appropriate next step in the management of this patient? So here you can see in Aruna what has happened. We have done a transvaginal ultrasound, and we found that her endometrial was thickened, and therefore we decided to do a saline sonography. So, what is saline sonography? You pass a saline in the uterine cavity and do a sonography, and you can see that it got delineated, and this diagnosis became endometrial polyp. So, when the endometrial thickness is more in postmenopausal, if it is 5 millimeters or less, it has 99% negative predictive value to exclude cancer. So we would have just gone and done a biopsy, but here we know it's a polyp. We can just do a histoscopic polypectomy and then send it for histopathology. So endometrial biopsy or measure serum LH, FSH, pelvic ultrasound, oral contraceptives? No. If it's postmenopausal Aruna, then it's better to do the sampling of the endometrium. It's always better to do it by hysteroscopy. You can use saline sonography to enhance your diagnostics so that you are in a better place to guide her. And if it is a thickened endometrium, remember to do it under hysteroscopy guidance, because then you do not miss on any cancer which is sitting in the corner of the endometrial cavity. So these are the various things that we are looking for, palm and coin as we understood, and various imagings which can be done. Hysteroscopy, you can see for polyp which has been done. You may consider doing an MRI if the patient has adenomyosis, or do a good ultrasound. Leiomyoma can be done by sonographic mapping. You may have to look for malignancy and look at the red flags, and we are going to come to that and discuss it. Whether she has polycystic ovarian syndrome, and especially we know that PCOS women in the perimenopausal age group would suffer from endometrial hyperplasia or ovarian cysts or malignancy, so we have to be careful with them. And then we can consider using an LNG IUS prophylactically in these women. And there can be also something which is called as an AV malformation or an endometrial pseudoaneurysm. So always remember various things while you're imaging, while you're interpreting. See these particular imaging modalities correctly and interpret. So now let's look at a patient who is presenting with abnormal uterine bleeding. And on the vaginal ultrasound, it shows a thin, distinct endometrial echo less than or equal to 5 millimeters bilayer. Then it's the abnormal uterine bleeding, and she's premenopausal or inactive. Then you can consider doing thinking and ruling out an endometrial malignancy. Central uterine echo more than 5 millimeters or endometrial echo not adequately visualized, saline infusion sonography. And if the thin endometrium is less than 3 mm, then don't get really worried. If it is symmetrically thickened more than 3 mm, then it's better to do an endometrial biopsy. If it's a focal lesion, asymmetric thickening, then do a hysteroscopic assessment. So whenever you have a postmenopausal bleeding, and you can see this is an histoscopic picture of an endometrial cancer, if the thickness is more than 3 mm, try to find out whether she is a high risk woman for endometrial cancer or if she's a low risk. If she's a low risk, then you can do an office endometrial biopsy and saline infusion sonography. Okay, and you can consider doing a hysteroscopy. If the endometrial thickness is less than 3 mm, follow, but symptoms persist. In women with continued bleeding after a negative initial evaluation, further testing with hysteroscopically directed biopsy is essential. So this is how an endometrial sampling is done. And if you look at the efficacy of office endometrial biopsy, it has been reported in various studies that the confidence interval is 7.8 to 18.6 for a positive test, and negative office biopsy test has a likelihood ratio of 0.2. And if the patient does not tolerate an office biopsy many a times, has cervical stenosis, the transvaginal ultrasound shows a polyp, an inpatient diagnostic hysteroscopy guided procedure must be performed instead, so that you have given her a thorough understanding and an evaluation. Sorry for that cough. Now, what are the risks for endometrial cancer? Irregular bleeding, obesity, which is associated with hypertension and diabetes mellitus, polycystic ovarian syndrome, diabetes, endometrial thickness of more than 12 mm. This I'm talking of women who are less than 40, family history of malignancy of ovary, breast, endometrium, colon, because there is a similar genetic BRCA1, BRCA2 predisposition of these patients, and they can have genes which can get upregulated to give them cancer. Use of tamoxifen for HRT or breast cancer, late menopause, and HNPCC, where there is a hereditary non-polyposis colorectal cancer. So these are the histories which you must ask in the patient, so that you are able to identify what are the problems in these patients and help them. So when we look at malignancy or hyperplasia, currently we are not doing that normal endometrium. We are looking at a normal endometrium, but then there are hyperplasias which are two kinds: complex hyperplasia with atypia and complex hyperplasia without atypia. And both of them have a risk. You can see if there is simple hyperplasia with atypia, then the risk of developing coexisting cancer can be 8. If it is complex without atypia, it is 3, but it is complex hyperplasia with atypia, then the risk of she getting cancer is about 30%. So this has to be remembered, and therefore, accordingly, you must interpret the histopathological reports. Abnormal uterine bleeding and age more than 35 years old, a typical glandular cells on PAP, biopsy of endometrium is essential. Hyperplasia, simple or complex, typical simple hyperplasia, then give progesterone therapy. Atypical cells, then it's better to do a hysterectomy if she's postmenopausal, or if she is premenopausal, do a dilatation and curettage or maybe a hysteroscopy, and consider giving her an LNG IUS if the reports come normal, or progesterone therapy. If the report comes cancer, then you have to go to the cancer surgeons and get a hysterectomy done. And usually cancers which are diagnosed very early in endometrium have a complete remission, and therefore that's something that we have to know. There's a new C endometrium classification which has come, and grading, which all of us must be aware of. Now, this looks like a very busy slide, and I think I'll have to wear my spectacles to read it. So, you will consider doing medical managements as we decided, and then based on the thickness of the endometrium, you will triage. And then, after doing a histoscopy or an imaging, you will decide whether it's a polyp, myoma, or nothing, and accordingly, you will decide medical management or a surgical management, a histoscopic approach, depending on her age, her needs, and everything. We will take into account. Now, just now, I had an unmarried patient coming to me. She was on oral contraceptive pills already, but despite that, and this was being given for her hemorrhagic cyst, but she has developed what is called as an endometrial polyp. She is just about 32. She may marry sometime, but then in this patient, the polyp is about 2 to 3 centimeters. We naturally have to remove it. We can't keep it because she may suddenly have an emergency bleeding, and that is what we have to explain to her. So measuring LH and FSH can confirm menopause but does not rule out endometrial cancer. So it's futile to do such tests. Pelvic ultrasound, good with uncertain findings on pelvic exam. Oral contraceptives are appropriate for patients with anovulatory bleedings, and but endometrial carcinoma always needs to be ruled out, and we discuss the risk factors. Now, what are the thromboembolism risks and history of one must ask for? Age more than 35 years and smoking more than 15 cigarettes per day, or using tobacco. Many of your patients are using tobacco in the form of mishri or otherwise. Multiple risk factors of arterial cardiovascular disease, such as old age, smoking, diabetes, hypertension, and family history of an IHD, hypertension, venous thromboembolism, known thrombogenic mutations, known ischemic heart disease, history of stroke, complicated valvular heart disease, risk of atrial subacute such as pulmonary hypertension, fibrillation, history of bacterial endocarditis, and systemic lupus erythematosus, positive or unknown antiphospholipid antibodies, and migraine with an aura at any age. So this is a classification which should always be in our mind whenever we are looking at our patients and triaging them and giving them treatment. So endometrial pathology is always better to be taken. Combined pills, always low dose, short pill-free interval. Or nowadays we have something similar to seasonal, which can be given back to back for 3 months for a longer duration. And estrogen, if contraindicated, then only give progesterone therapy. Ormaloxifene, 30 milligrams or 60 milligram, can be given twice a week for 6 months to a year. LNG-IUS is something which we very frequently use if there is no contraindication. And one can consider doing a trans-cervical resection of endometrium, use a balloon therapy where cryo is used through the balloon. And if the endometrium is not accessible, then it's always better to go ahead and do a hysterectomy. Now let's look at Anjali, who is 46-year-old woman, presents with complaints of intermenstrual bleeding. Her LMP ended 10 days back. However, for the past 3 days, she has noticed bleeding requiring 3 to 4 pads. And she reports that before this, her periods were regular, lasting 5 days with occasional light menstrual bleeding over the last 6 months. She is sexually active in a monogamous relationship and uses barrier contraception. Afebrile, normotensive, little bit of raised blood pressure, which is okay because she must be anxious. Negative orthostasis, and the pelvic examination reveals a slightly enlarged globular uterus with blood noted in the cervical os, and the pregnancy test is negative. So, what is your diagnosis? Adenomyosis, and get confirmed on transvaginal ultrasound, where you find that there is a globular uterus with cystic anoic spaces in myometrium. Uterine wall is thickened, anteroposterior asymmetry, subendometrial echogenic linear striations, heterogeneous echotexture, obscure endometrial or myometrial border, and thickening of the transition zone between the endometrium and the myometrium. And you can see if it is more than 12 mm, then you should be on guard. And this probably can also be an adenomyoma if it is localized. There can also be AV malformations where there are multiple communications between the arterial and the venous systems without an intervening capillary network. And these are usually iatrogenic because of intrauterine instrumentation in the form of DNC, myomectomy, cesarean sections, or curettage, or any septum resections or anything like that. And these are serpentinous tubular anechoic structures within the myometrium with a low resistance, and USG with color Doppler is the choice. So, which of the following is the most appropriate next step in the evaluation of this patient? MRI, transvaginal ultrasound, hysteroscopy, reassurance, and monitoring. There's no need of doing an MRI and unnecessarily spend the patient's money. So, it's always better to do a transvaginal ultrasound. Of course, if you are trying to do any reparative surgery or fertility enhancing surgery, then you are justified in doing a MRI. Otherwise, there's no need to go ahead and do an MRI. So, you can see here these are fibroids which are seen on MRI. Ultrasonography is showing endometrial thickness. Transvaginal sonography is always the best approach. So many times I find people giving treatments based on transabdominal sonograph. Don't do that. Because many times what happens is the patient's lower pelvic obesity will preclude the correct assessment and your diagnosis may go wrong. So always encourage to do a transvaginal ultrasound. Sonohysterogram, where you are passing a saline infusion sonography, and this is hysteroscopic evaluation, and you can see that there are intracavitary fibroids which are seen on hysteroscopy when the uterus has been distended. So MRI is not the primary imaging. Transvaginal ultrasound is important in this patient with AUB, and would consider endometrial biopsy as if she's more than 45. Hysteroscopy SI should be done in patients with concerning uterine cavity findings in TBS, and monitoring would not be appropriate in the setting of abnormal bleeding and concerning physical examination. So always evaluate quickly and give them answers. Now here you can see this is an endometrial polyp, and then when you do an SIS, it got delineated, and you can see it on a hysteroscopy. But sometimes you may see something like this. And what is this? This can be synecdoche or fibrosis, where the patient has undergone maybe puerperal sepsis in the past, or tuberculosis, or Asherman syndrome, MTP, which was very difficult. She had sepsis after that, or very harsh curettage was done. Then this can be the picture. And you can see this is an Asherman syndrome, all synecdoche formed in the uterine cavity. And this patient can have a lot of hell of a time, especially if they're trying to get pregnant. So again, remember at your classifications, as I told you, always keep this chart in front of you. And in our patient, we have to see, so she had polyp and then maybe malignancy and hyperplasia, which has to be ruled out. So pathway for heavy menstrual bleeding comes with all the things that we have discussed here. There's nothing additional in this chart. But there are certain recent research highlights in HMB which we should be aware of. And are there any genetic insights? A genome-wide meta-analysis involving over 84,000 HMB cases and nearly 6 lakh controls identified 36 genetic loci associated with an HMB, including 33 novel ones. An F5-laden variant showed a strong protective effect, suggesting a link between coagulation pathways and HMB. Genes involved in hormone regulation and want beta catenin signaling were implicated, pointing to new therapeutic targets. And strong genetic correlationship were found with uterine fibroids, endometriosis, and ovarian cysts, reinforcing the shared pathology. So this was a study which was published from Netherlands, which is called as Healthcare Access and Stigma, and this is something that all of us should be there available for our patients. This was a study by the neighborhood feminists revealed that over half of individuals with HMB do not seek medical help, often due to stigma and lack of awareness. And HMB significantly disrupts daily life, work, and relationships, yet remains underdiagnosed. And the report advocates for improved provider training, policy changes to support menstrual health, public education to normalize menstruation discussions, and there are certain clinical practice implications. These findings support a more personalized and individualized approach. HMB assurance, don't scare them. Considering genetic predispositions and social barriers, some genes may get upregulated because of an abnormal lifestyle and predisposition factors. Encouraging early screening for fibroids and endometriosis in patients with unexplained HMB. So if you try start treatment early, many times patient will come for treatment, then somebody tells them don't take these hormonal treatments, they'll go back and then come back with an increased fibroid, which can be a problem. And highlight the need for empathetic communication and multidisciplinary care. Now, there is a new kid on the block, and that is Egolix, which can be used in abnormal uterine bleeding, which is an oral GnRH antagonist that has shown promising results in managing HMB, especially associated with fibroids. And it causes rapid and reversible suppression of ovarian sex hormones, reducing estrogen and progesterone levels. And this has been studied in the clinical trials UF1 and UF2, where women were given Egolix 300 milligram twice daily plus add back therapy with estradiol 1 milligram and norethindrone acetate 0.5 milligram. And it was found that there was more than 50% reduction in menstrual blood loss. Add back therapy is essential to mitigate hypoestrogenic side effects like bone loss and vasomotor symptoms. And HMB due to fibroids, short-term management, alternative to GnRH agonists, which are given as injectables, can be considered when we are giving Egolix before we prepare her for surgery and correct her anemia. It is not a first line for general AUB and contraindicated in pregnancy. And please monitor bone mineral density with prolonged use when you are giving them. What is the place of hysterectomy in treatment of AUB? Pressure symptoms of severe bleeding are not responding to treatment. Some tumors may cause AUB and in older women necessitate hysterectomy. No response to medical conservative treatment. After thorough evaluation, postmenopausal bleeding, you will then consider hysterectomy despite there being everything normal, and adenomyosis or endometriosis, which is resistant to treatment. This is how the levonorgestrel intrauterine system, which is placed in the uterus, and it's always a good practice to place it prophylactically. Many times in patients of diabetes, hypertension, PCOS, obesity, after they finish the childbearing, I suggest you put in an LNG IUS so that you won't get the repercussions later. What is advantageous is there are no peaks and troughs as with oral dosing because it's already placed inside and there is a local secretion or release of the levonorgestrel, which is very, very less in the plasma. So there is no first pass effect, no side effects, and it acts locally effectively. And it has been found that levonorgestrel intrauterine system in an Indian study has shown to reduce the need of hysterectomy by 85 to 90%. So it's a very good prophylactic medicine to prevent problems associated with abnormal uterine bleeding. And then we can consider, you can see that this is a cryotherapy with a balloon, and this is a TCRE, which is done hysteroscopically, where you do a transcervical resection of endometrium. Now, unfortunately, in the rural part of our country, many doctors turn to hysterectomy because patients demand. But remember, please don't do hysterectomy. This is a Government of India guideline. It says that no hysterectomy before the age of 45 unless and until it's mandatory. And then if you do it, you will be expecting there going to be an audit at your facility. And remember that the state of Maharashtra has created, and I have been part of that, we have created guidelines wherein you can give these treatments which I was discussing right now. So at the end, I would like to thank you for giving me this wonderful stage and an opportunity. And consistency, clarity, and commitment is something which is extremely important, and that's what matters. Thank you so much for giving me this time, and I hope I have been able to deliver uh, everything correctly. So there is a question which I can take, Sanika.
There are multiple questions we can take if you
Okay,
want.
you just guide me what to do, huh?
Yes, yes, ma'am. We have a question here by Dr. Rajendra Purohit. Is what is the dose of tranexamic acid and injection botropes?
Injection botropase, I don't
Botropes.
have any experience, and nor are we using it in AUB. There is no recommendation or guideline. Dose of tranexamic acid, I did mention in my talk, 1 to 2 grams per daily. Start off with 1000 milligram if she is very is bleeding heavily, and then after 4 to 6 hours you can give her 500 milligrams, and give it for about 3 to 5 days, and that should do the trick.
Uh, what which OCP can we prescribe in heavy menstrual bleeding? Dr. Nivedita is asking us.
In which bleeding?
Heavy menstrual bleeding.
So you can use, it's always better to use a gynecological formulation. Find out whether you have a patient who is hyper or hypoestrogenic. If she is an hyperestrogenic, then you can consider a low estrogen pill, or if she is hyperestrogenic, then you can give her a 30 or 35 microgram containing estrogen. Along with, it's always better to first start with levonorgestrel, because that is known to cause the least thromboembolic episodes. And whenever you're prescribing a pill, always call the patient back again after a week and tell her about early warning signs where she has to report to your facility. Don't scare her, but assure her, and that is important. And then maybe after you have controlled her bleeding for a period of 3 cycles, you may shift her to a low dose contraceptive.
Ma'am, this is not a real patient but a query. Is can we prescribe tranexamic acid to a patient of coronary artery disease who is on
Ideally, I
APs?
don't think so. It would be right to do that, because when we are prescribing tranexamic acid, this coronary artery disease is not your patient any which ways. The physicians and the cardiologists will go in a tizzy. They don't like us giving tranexamic acid, so don't give. No, why you want to give her? She's already taking ecosprin, clopidogrel. You have to consider something else for her. I have also gone and done balloon tamponades in some patients. And then in some patients where the reproduction is not the thing, we have also done ovarian radiation in radiation center. Or you can give them, the onoloxofen, which is quite safe.
Uh, Drug of choice which we can give
There's
in
nothing like a drug of choice. You must have realized that there are so many cases which I told you. It's always individualization. Be very attentive to the patient's history. Try to make your own understanding why she's bleeding, and then accordingly treat her. Follow the palm-coin rule.
Dr. Pooja Banit is asking, is HRT to be given concurrently with edolits?
It's always better to give, especially if the woman is perimenopausal and towards the later part of her menopause, because that will help her in maintaining her bone mass,
Okay.
and she will have less bone pains. But there is no replacement for exercise. You have to do stress bearing exercises.
And continuation of the same, I think. Which conditions with AUB can
We did
we?
mention fibroid, adenomyosis, and endometriosis.
Okay. Uh, there is a question by Dr. Darji. Role of ethamsilate, is it better than
So
mefenamic acid?
ethamsilate and mefenamic acid are two different things. Ethamsilate is a hemostatic medicine, while mefenamic acid is an NSAID, and they can be given in combination for better effectivity.
We have a question here by Dr. Ishita. Is continuous heavy menstrual bleeding after Mirena insertion?
So
How do we?
basically, yeah, it's possible that you have probably not done a proper evaluation. Just do a ultrasound, check whether the mirena is in place. Find out why she's bleeding. There can be a subclinical infection, treat it with antimicrobials. You can step up giving her a high progesterone dose, or maybe supplement with her estrogen if it is not contraindicated. And usually that will take care. Or you can just give simple hemostats, like one which I commonly give with women because they are perimenopausal is anafortan and mefenamic acid combination. That also works well because it is safe, doesn't have any side effects or acidity, which can be given twice daily for 5 days alongside an antimicrobial, and then see.
Uh, I think it's a continuation of the previous one here by Dr. Pooja. Is there how long can edolets be given?
Egolix. So if you are giving it for a symptomatic treatment, then it's always better to give it till the symptoms are relieved. So normally now I'm giving it very commonly in my patients of endometriosis and adenomyosis, and I feel that within 4 or 6 weeks they have complete remission and relief from symptoms. So that is the point time when then I've started with a 200 milligram OD or BID. If the CA 125 is very high, then I gave BD. and then we shift on to a lower dose, 150 milligram BD, and then maybe 150 milligram OD, and then continue that. And once the symptoms have reduced, then we start her on oral contraceptive pill. And always, always, whenever I write Egolix, I mention on the prescription you have to do exercises, you have to be mobile, and you have to take calcium, vitamin D supplementations as well as good dietary supplements.
And can it be given in a younger patient?
Yes, sometimes you may consider giving it in a younger patient as well, but it's better to give it only after 18 years of age when she has had her joints which are fused, because finally it is a GnRH agonist, so it may, cause her stunting or something like that.
Okay. Ma'am, here is a question on how to diagnose the hypoestrogenic and hyperestrogenic.
Usually, patients are very typically obese. They are very fair. They are beautiful looking women, and they would have all these kind of conditions where they have fibroids, they have breast fibroadenomas, and irregular cycles or heavy menstrual bleeders. These are usually hyperestrogenic women. Hypo are typically PCOS, hypothyroid, little androgenic women will be typically hypoestrogenic.
And ovulatory and anovulatory type of AUB.
That you will have to be patient. Look at the cycle, look at her history, find out whether she's ovulating or not. That will give you an answer. If the cycle is regular, usually it is an ovulatory cycle. If the cycle is self limiting, it's usually an ovulatory cycle because it's a withdrawal of estrogen and progesterone. If it's regular, that means she has ovulated right on time and therefore she is having a cyclical cycle. So that will tell you that she's ovulating or not. But there is something like a sub-ovulation and all that also. So we have to be looking at the histories carefully.
Yes, I think that are all the questions. Ma'am, if you have a part in to-do list or things to remember, sort of a
So keep that AUB
feeling.
palm coin classification on your tables. Be very patient. Please remember, women don't come easily to ask you for bleeding. Don't be impatient with them. Try to guide them. Don't pick them all for a hysterectomy. There are so many wonderful things. And especially whenever women are coming to you in earlier ages, try to do the risk assessment. Whether this is going to be a patient for AUB, do not look down upon oral contraceptive pills. Many clinicians guide the patients against oral contraceptive pills, but remember, it's the time tested medicine for the past 75 years. And today, women are marrying late. Menstruation starts at one time, then their marriages or children happen later. Till that time, there's a lot of tissue injury and repair sequencing. So they are at risk of developing PCOD, endometrial polyps, endometrial hyperplasia, and then they may have endometriosis, adenomyosis. So it's always better to start an oral contraceptive pill in such patients at risk. If they are sexually active, all the more reason prescribe them to take COCs. Don't tell them to use those emergency contraceptives which are not very healthy. So these are the tips that I would want to give. Please have a very, very positive assurance about oral contraceptive pills because they protect women mentally, physically, bone health, heart health, and everything. Plus, they reduce the possibility of cancers of the ovary, cervix, fallopian tube, and the endometrium by about 35 to 40% if taken for a period of 5 to 7 years during the reproductive age.
Thank you so much, ma'am, for answering the questions and as well as for your presentation. It was extremely insightful.
Thank you, my dear.
And there are so many appreciative comments in the comment box right now as well.
Okay, thanks a ton. I hope, finally, the reason I agree to whenever you invite me is always because I feel that this is my opportunity to reach out more people and try to help women's health in a better way. Thank you so much for giving me this opportunity.
Thank you so much, ma'am, for joining us today.
Yeah, bye bye.